Welcome back to Abnormal Psych. This lecture, health. Health is linked to abnormal psychology. Sticking with just the major abnormal psychology problems, anxiety, psychosis, and depression, we can say that high blood pressure can cause anxiety, high body temperature could cause hallucinations, we're all just a few degrees away from hallucinating, and inflammation can cause depression. This lecture first discusses the basics of how your mental and physical health are part of the same system, and then we move on to some cases where mental health issues stem from how people perceive or think about their health. So, abnormal psychology and health, followed by abnormal psychology about health. In Intro Psych, we told you about the stress experiments. We asked people to tell us how stressed they were feeling, and then we exposed all of these people, regardless of their stress score, to viruses. And the more stress you reported, the more likely you were to get sick as a result of the virus exposure. The best understood aspects of how this happens are contained within the hypothalamic pituitary adrenal axis. Most hormone release in your body is controlled by the hypothalamus and the pituitary gland. The mind changes the body by influencing the hypothalamus, which stimulates the pituitary, which is so important that we call it the master gland. Sticking just in the realm of stress, the posterior part of the pituitary gland controls the release of the hormones that determine your blood pressure, and of oxytocin, which, in addition to making us more socially affiliative, also provides a buffer against stress. Your tend and befriend hormone. Depicted here are two different systems that are taking signals from the brain and using them to influence the body. First, you have the endocrine system. Descending signals from your cortex influence what the hypothalamus tells the pituitary, the master gland, to do. The pituitary signals in part through adrenocorticotropic hormone, the adrenal glands, and others, to release various hormones, including cortisol, which is our typical biological measure for stress. More cortisol release, more stress. So that's the hormonal side of things in your endocrine system. On the other side, we have your autonomic nervous system. Activation of the sympathetic nervous system influences the adrenal glands, in this case, the adrenal medulla, the center of the adrenal glands, to release epinephrine and norepinephrine, i.e. adrenaline and noradrenaline. So through these two systems, the sympathetic and the HPA axis, we connect what's going on in your mind, your messy 3 pounds of meat that thinks, with the consequent changes in your body. Note that this does not mean we expect to be able to control how the mind influences the body. The door is open for that to a limited extent, but for an accessible example, think of a time when someone startled you. The startle caused an initial jump, an initial reflex, but then nearly immediately you realized that there was nothing to be scared of. Despite the fact that you then knew there was nothing to be scared of, there were still lingering effects in your body, heart rate, vigilance, faster, more shallow breathing, and these effects typically only reach their peak after you've already figured out that the startle was nothing, that there's nothing to actually be scared of. This is in part because hormones have a slower, more gradual onset and offset compared to the near instant startle response. So in this case, simply knowing that there's nothing to be scared of doesn't make the hormonal response go away. It takes a little bit of time for the arousal to subside. There are some things you could do to influence this in a rather minor way. Intentionally slowing your breathing can help get your heart rate back down more efficiently, or going in the other direction, getting very angry at the person for startling you, could keep you in your agitated state, keep the arousal going. So there are choices you can make that influence the offset of the biological response, but there isn't a choice that you can make to not have the response, or suddenly switch it off. Now, the fact that there are these two systems linking what goes on in the brain with the functions of the body means we don't have an excuse. We can't say that what we think doesn't influence our health. We can, of course, take that idea too far, but to not take the idea at all would be foolish. Our thoughts influence our health. Not magically and directly, but generally and over time. Through the overproduction of cortisol, epinephrine, and norepinephrine, we see influences on the production and functioning of cells in the immune system. Pictured here is your lymphatic system. When your doctor touches you around the neck and under the armpits, she's checking for inflammation of lymph nodes, because when you have infected tissue, it gets marked, killed, and transported into these lymph nodes, so if you've been fighting off an infection, they will be swollen. We know that there's a connection between stress and depression, and this shouldn't be too surprising, but one question might be, how physically is stress connected with depression? The most well-researched answers to this question start with cortisol, the glucocorticoid stress hormone that makes cytokines, specifically interleukins, inflame your tissue and organs. Interleukin 6, for example, which is a pro-inflammatory cytokine, sometimes in response to stress, what you need is inflammation. If what is stressing me happens to be an injury to my skin, then inflammation could very well save my life from bugs and bacteria, or maybe even blood loss, by inflaming the damaged tissue, keeping what should be in and what should be out, and also drawing to the inflamed area needed resources for disinfection and repair. But levels of interleukin 6 predict depressive symptoms, which in turn may influence and increase levels of cortisol and interleukin 6, which may or may not be helpful. I'd like to point out that it may be helpful, because what are depressive symptoms? These are negative emotions, these are withdrawal types of emotion, and if you are injured or sick, it may be the case that these are the emotions, or absence of emotions, that would be most adaptive if they were the ones most likely to improve your physical health or make sure it did not deteriorate further. So cortisol is our primary stress hormone. We use it as an index of stress over the longer term. Specifically, I can assess your level of HPA activation for the past 4 to 6 months by assessing level of cortisol in the roots of your hair. More commonly in psychology lab studies, we'll use saliva or maybe urine. So we might have a simple manipulation where half of participants are randomly assigned to be asked questions that make them nervous or to engage in a stressful task, and we're interested in whether the stress influences performance, but we need to know that the people were actually stressed. And one way to get around demand characteristics, i.e. people telling us they were stressed because they figured out that we were trying to make them stressed, one way around that would be to take all participants' urine at entry and check the cortisol levels, and all participants' urine at the end of the experiment, and see whether those participants who were in the stressful condition did indeed have elevated levels of cortisol in their urine, higher at time B than time A, and higher than the non-stressed controls as well. The other stress hormones here you may recognize as neurotransmitters. Norepinephrine and epinephrine are neurotransmitters, but they also enter the bloodstream. The adrenal medulla, when activated, and a typical activation course might be the amygdala activates the hypothalamus, which activates the release of norepinephrine and epinephrine from the adrenal glands, specifically from the middle of the adrenal glands, the adrenal medulla. Since the adrenal medulla releases these into the bloodstream, they are, by virtue of being transmitted through that route, going to have the effect of hormones. Slower onset, more gradual offset, and with a change in place comes a change of name. When they were being released into synaptic clefts and aiding in transmission of signals neuronally, they were called norepinephrine and epinephrine. When these same substances are doing their work by traveling through the bloodstream and activating receptors, for example, in cardiac tissue, we're calling them noradrenaline and adrenaline. Same substance, different place, and therefore different action. What is this action? Well, both norepinephrine and epinephrine increase heart rate, blood sugar, and blood pressure. Both are released by the adrenal medulla. Epinephrine or adrenaline also aids with breathing, which is why for anaphylactic reactions we have epinephrine pens or EpiPens to help facilitate your breathing. And the presence of adrenaline in the bloodstream improves muscle performance as well. It is not uncommon to measure as an index of stress epinephrine in urine as well. One way to tell whether we did indeed surprise someone or stress someone or get them into fight or flight mode would be to check to see whether we increased their urinary levels of epinephrine. Okay, what do these stress hormones have to do with immunity? What do they have to do with your getting sick? Shouldn't it be the case that if you're stressed, you fight off sickness better because your body is in defense mode? Well, no. The big issue for stress and immunity is if you are in fight or flight mode, you may be using your immune cells, those memory B cells that you got from your flu shot, your helper T cells that tell you to grow more of those memory B cells. You may be using these cells, but you're not replenishing them. The immune system needs time in parasympathetic rest to regrow cells, restock its T cells and B cells, and if this isn't done, you have lower immune performance, less ability to fight off things, even things you're quote-unquote immune to. You are only immune to some things because you are capable of fighting off those things. I am unlikely to get the chickenpox virus because my immune system learned through exposure how to fight off the chickenpox virus. It still has to do that fighting if I get exposed to that virus, though. So two things could go wrong. My cells could not be ready for the exposure. Maybe I've been in stress for so long that I haven't been quote-unquote restocking my immune system. Or I could be ready, but be exposed to such a high viral load that I don't have what it takes to fight off all of the chickenpox antigens that I'm being exposed to. The damaging effects of prolonged stress were illustrated very nicely by Hans Selye in his general adaptation model. We have the initial alarm stage, the resistance stage, and then the exhaustion stage. Maybe the stress kills us, or maybe we return to homeostasis. Either way, there's a period where our resources are depleted because we're not restoring them. And the more we stay in fight or flight, the more our parasympathetic rest and digest system is suppressed, the more likely we are to succumb to things that we normally would have fought off without even noticing them. Your body is, right now, probably fighting off something, but prolonged stress can compromise our ability to fight these things off, which is why it's related to ulcers, because normally we keep the bacteria responsible for ulcers in check. If we're under stress, maybe we're not as good at doing that as we normally would be. We saw that prolonged activation of epinephrine could lead to hypertension, which is a self-perpetuating problem, in part because the heart is a muscle, and if it beats more intensely, it might get stronger and continue to beat more intensely, but also because of a wearing down of the blood vessel walls. As some of you probably know, continued stress exacerbates asthma and lowers your immune system's ability to fight things off. And most of the research that shows us the damaging effects of stress on immune functioning is research on chronic stress. If you've had a family member in chemotherapy for years that you're taking care of, then this would count as a chronic stressor. One of the most stark examples is individuals who are the caregivers for partners or parents or family members who have serious disorders, especially progressive dementia like Alzheimer's. If you are the primary caregiver for a loved one who is experiencing the progression of Alzheimer's dementia, this increases not just how long it takes you to heal cuts or how vulnerable you are to infection, it also increases your overall chance of dying, whether this is from infection or accidents or heart attacks. If I am an actuarialist figuring out how much you should pay into a life insurance policy, I'm going to see in my numbers that you have fewer years of life expected. If, as in this study, we're looking at an individual who is the caregiver for a spouse who is experiencing Alzheimer's dementia, we would take whatever their health risk was otherwise, whatever their chance of dying in any given year was, and we would multiply that number by 1.63. So whatever your chance of dying next year was, before accounting for the fact that you are looking after a spouse with Alzheimer's, I would take that number and multiply by 1.63 and say that that is how likely you are to die next year. But all this talk of measurable biology and falsifiable predictions about how long people will live might be giving us false confidence in our ability to understand stress. Richard Lazarus gave us a model that reminds us that in part it's the case that thinking makes it so when it comes to stress. In part. If someone calls me a donkey, the degree to which that is stressful for me is going to depend on what I think about the insult, its performance, and the person making it. So we have, again, the fact that our psychology intervenes in the process of determining our bodily response and well-being. And as with anxiety, we are opened up here to the possibility of self-destructive loops. Take, for example, pain catastrophizing. Things feel worse because you expect them to, which, by normal, correct learning, should make you expect things to feel worse, and so on. Lazarus's interactionist model of stress and response says that the ultimate arbiter of stress is perception, and perception requires appraisal. So there are things, events, circumstances that could cause stress, but this stress is ultimately determined by our interaction. The events or the donkey insult has to, in a sense, be filtered through my gray matter. My messy 3 pounds of meat that thinks needs to perceive the insult in a given way in order for the insult to cause me stress. So by Lazarus's model, stress arises when the situation is threatening or challenging or harmful. So there's lots of room here for what Lazarus said were the 3 different types of appraisals that we make as we interact with things that could potentially be stressful. There's primary appraisal, where we make an initial pass and we bin something as potentially stressful, good, bad, confusing, absurd, irrelevant. And secondary appraisal under this model is essentially an appraisal of ourselves with respect to what caused the primary appraisal. Can I deal with this problem? Are there steps that I can take to mitigate the problem? Should I upregulate or downregulate my emotional response? And can I? And once a cycle of primary and secondary appraisal has been accomplished, your tertiary appraisal type is reappraisal. So, someone called me a donkey. Is this stressful? Well, they called me a donkey in front of some people who I want to impress. Secondary appraisal. Can I manage this goal of handling the donkey insult in a way that makes me look good in front of the people that I want to impress? Well, I could demonstrate to these people that the donkey insult didn't bother me. I am neither shaking nor red with concern, so if I remain calm, everyone will see that it's not bothering me, so I think I can handle this. And then in the tertiary stage, you see whether the person insults you again or whether the people are responding the way you'd like. And a change to either of those things could change your primary and your secondary appraisal conclusions, which could change the amount of subjective stress you're experiencing. This brings up an important 6-letter word, coping. Lazarus just demonstrated with the concept of reappraisal that coping is a process. It's you adapting your appraisals to the situation, and it is not just interactive in terms of your coming together with the situation, it is also active. There's no autopilot trick that can handle every stressful situation, at least not adaptively. Coping with stress requires effort and active management, and this is one thing that a good therapist will stress. Coping is about management and not necessarily mastery. The prototypical example here being someone who expects to have complete control, to not have any buttons that can be pushed, or to have every potentially stressful encounter go the way of their best stressful encounter that they've had. Just because you handled something well once, this is not grounds for inferring that the next time you will handle it as well. Just because you sunk a 3-pointer the last time you shot from the 3-point line doesn't mean the next one's going to go in. And this is a mistake of expectation that we have with other people as well. Sometimes my toddler is a model of self-control, and patience and politeness and attentiveness. But I do him no favors if I expect his best performance all the time and am disappointed in him if he doesn't meet his previous best. Stress and our response to it is something to be managed. Expecting perfection or mastery is just asking for the installation of negative loops. So now that we have this idea of coping, and hopefully we've taken some of the pressure to be perfect off, we can look at what different sorts of coping one might respond with. You can pick your favorite from the list here. I'm going to take a guess and say most of you use the bottom one. I tend to use the second from the bottom, which is a healthy defense mechanism. But as you can see, we've got options. And our health outcomes will be determined in part by which option we choose. This is part of a broader observation in health psychology, namely that the behaviors we engage in are the biggest determinant of our health. To take an example that probably wouldn't get any argument, smoking. This is a behavior that we choose to engage in, though in the case of addiction to cigarettes, the word choice doesn't quite capture how challenging it is to engage in the healthier behavior of not smoking. Consequences of engaging in the behavior of smoking include reduced immune health and increased subjectively and objectively measured stress. The flip side here would be a behavior which improves health, such as exercise. Mild to moderate cardiovascular exercise, i.e. doing something that it's difficult for you to talk through for 20 to 30 minutes a day, improves your breathing, circulation, thinking, digestion, and immune health. It even helps you fight cancer, specifically through improving your immune functioning, and makes you more satisfied with the life that you save. I choose smoking and exercise as my examples because they are each equally abnormal in terms of the I in our SNIDS model in frequency. Specifically, in Canada, rates of smoking are at about 15%. About 15% of us smoke regularly in Canada, a number that's going down gradually. And if you look across age groups at the percent of Canadians that get the minimum amount of recommended exercise according to Health Canada, that number is 15%. So smoking cigarettes is as statistically abnormal as getting the minimum recommended exercise in Canada. One of the ways that exercise reduces stress is by improving the body's ability to tolerate stressful things. It's called the adaptive hypothesis, and it goes like this. Exercising, specifically cardiovascular exercise, is stressful. It's a type of stress. But it's a type of stress that somehow improves how our body responds to stress. The way I typically narrate it is your body learns that it can handle running 5 kilometers, so when it encounters a passive-aggressive boss, it says, well, this is nothing, this isn't stressful. And since you now have that higher threshold for stressful, your body physically gets kicked into fight or flight less often. And less time spent in sympathetic arousal, in fight or flight, means more time spent in parasympathetic, rest and digest, so your immune health and cellular repair will be better with than without exercise. But the adaptive hypothesis is rather simple. There's a more integrative approach to explaining why exercise is good for health and for stress management specifically, in the fact that exercise is a stressful thing that we choose to do, and it can be important to our self-concept and to our experience of ourselves to choose to do difficult things and see them through. And since, with cardiovascular exercise, the body gets better at it so rapidly, so efficiently, the exercise provides a sort of object lesson in how we humans are anti-fragile and actually improve in response to stress or the meeting of challenges, rather than just being passively eroded away by them. But we're touching on something at the psychological level, or dimension, that turns out to be quite important, which is your sense of agency, impact, efficacy, i.e., how much do you think that your own actions and decisions effectively shape or determine your life? If you think that what you do doesn't matter, then you'd be a fool to try something difficult, or to even think about how you could improve your own life. But if you think your effort will pay off in improvement or success or useful learning, well, then you'd be a fool not to tackle the problem. Not surprisingly, individuals with a higher or stronger sense of personal control and responsibility tend to cope better with stress. If you think that control over your life resides within you, then you have what we call an internal locus of control. And in the context of stress, this turns out to be beneficial for the individual, i.e., it's beneficial for the individual to believe that they have some sort of personal control over the circumstance, the stressor, and their response to it, because the absence of this sense of control makes things more physically and subjectively stressful, as measured by stress hormone production. Note that the relative advantage of having an internal locus of control is not some absolute statement. We are not wrong when we point out that circumstances influence our behavior. And as previously mentioned, the expectation of complete mastery or control can be quite counterproductive. Next, abnormal psychology about health. If we stick once again to the big three of anxiety, psychosis, and depression, we see that those with anxiety might report excessive fears about their health, catastrophizing physical symptoms, and present with problems like accelerated heart rate and shortness of breath that could be caused, quote unquote, caused by their anxiety, but these symptoms may also cause more anxiety, and hence the symptoms may then cause themselves. Since if anxiety about heart palpitations is warranted, then it's only logical to get more anxious about heart palpitations that the anxiety initially caused, thus causing more palpitations. Whatever set off the loop originally, the anxiety or the symptoms, could be irrelevant. In other words, the functional autonomy of your disordered anxiety and bodily symptom loop could be, and I stress could be, your actual problem, in the sense of finding the pathology. But at the source, or the genesis, or the onset, we have somatic symptoms derived of anxiety. Those with psychosis could quite easily be led by a delusional understanding of their bodily symptoms to believe that, for example, they are being slowly poisoned, or they could elaborate on a rather minor hallucination and report that they've been having blood in their stool. This could lead them to shine an abnormal light on normal bodily variations and come to believe and report that they have illnesses and symptoms that they do not. With depression, clients will have genuine neurovegetative symptoms, like lethargy, lack of sex drive and appetite, and attention to these things could similarly, as with psychosis, lead to pathological interpretation of normal variation, or, as has been observed, enhancement of subjective discomfort, especially the experience of pain is well observed in clients with depression. So I'm going to try to touch on all the corners of the somatic symptom and related disorders category in the DSM-5, and at the same time attempt to communicate why I think it might not be a good map of the territory of somatic symptom disorders. So first, let's orient ourselves. What are some current perspectives on somatic symptom and related disorders? A nice concise characterization of somatizing or somaticization comes from Boone in 2017. Clients have psychological distress, but they don't identify it as psychological distress, so they look for justification of their distress or representation of their distress in physical symptoms. Now, the physical symptoms may or may not be real. What matters for the diagnostic category is that the individual is suffering something. Even if they have only completely imagined their physical symptoms, they are still suffering by virtue of thinking that they have those physical symptoms. So in that case, we could call it psychic distress. The key point for the DSM and related perspectives is the individual's suffering is authentic. And we don't have to work too hard in order to justify or imagine justification for a mechanism that creates this sort of suffering, especially if there are others to respond to it and help you. The general model used for somatic symptom disorder is the idea that your somaticizing is in part a form of self-deception. You're convincing yourself that you either have physical, medical symptoms, or that they are worse than they actually are, or more systematic than they actually are. The broader intended purpose could be to protect one's own ego or to deceive those around them. Either way, the client has, in part, deceived themselves into miscalibrated or erroneous interpretation or experience of physical symptoms. When it is believed that the individual themselves is not actually a believer of this deception, that is, when someone is presenting with physical complaints, but we think that they don't actually have the type or magnitude of symptoms that they're presenting, then we have categories in the DSM for this other deception, one of which is malingering and the other is factitious disorder, which is a somatic symptom related disorder. But as many of you might be quick to point out, separating other deception from self-deception is not a neat process, and likely subject to change across time. I may start out by deceiving other people and then come to believe my own lie. It's actually quite common. This is how some people get so good at lying. They start believing their own lies, or exaggerations or self-serving interpretations. Related to this is the problem of coming to understand yourself through some sort of pathological lens. There is a very large existential difference between saying you have a headache and you are a sufferer of headaches. One is an event, the other is an identity. Moving a little deeper now, the acronym MUPS comes up in the somatoform and somaticizing literature. It stands for Medically Unidentified Physical Symptoms, which on one level is a contradiction, because how can you be said to have something that can't be found? But on the other level is an absolute necessity, because we can't, with our limited knowledge, identify the source and rhyme and reason of every physical symptom of which someone complains. So there will always be MUPs, because our knowledge is finite and imperfect. But it will also always be somewhat of a definitional problem to label something as a symptom that hasn't been identified. MUPs are important to the category of somatic symptom and related disorders. It is in part because we have individuals with medically unidentified physical symptoms that this category exists. But medically unidentified physical symptoms are neither necessary nor sufficient for one to get a diagnosis of a somatic symptom or related disorder. Not sufficient because you also need distress or some sort of disruption or burden in order to meet threshold for a diagnosis. And not necessary because you can have a physical symptom that has an identified source for which the problem is your calibration. Maybe you're overinterpreting or catastrophizing the symptom, in which case the problem isn't a medically unidentified physical symptom, it is your response to it. And importantly here, diagnosis, and the quote comes from the DSM, is based on positive symptoms and signs. So not what's missing, but what's there, like reports of distress and somatic symptoms, and abnormal thoughts, feelings, and behaviors, like catastrophizing or withdrawing in response to the symptoms. The cognitive therapy approach is pretty predictable and emphasizes catastrophizing, whether it's pain catastrophizing, overinterpreting bowel discomfort. Cognitive therapy is there to get people thinking more realistically, more well-calibrated to actual magnitude, actual risk, actual likelihoods. Not surprisingly, the psychodynamic approach has a lot to say about somaticization disorders, not least of which is that if you want to actually address the problem, you're going to have to find the unconscious conflict responsible for the physical manifestation that is your somatic symptoms. A word of caution is warranted here because the way somatic symptom disorder is framed could be very important for the individual's willingness to continue in therapy. Regardless of which paradigm you're using, if you frame the treatment of the disorder as convincing them that they don't have a problem or finding out where their understanding of themselves went wrong, you're likely to set up right off the bat an oppositional type of relationship. Best practice would likely be just to frame therapy in terms of understanding the physical symptoms and chip away at the insight psychology approaches more gradually and incidentally. So let's start with the flagship of the somatic symptom and related disorders category. Somatic symptom disorder. One or more somatic symptoms that are distressing or result in significant disruption of daily life. Excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns as manifested by at least one of the following. Disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxiety about health or symptoms, excessive time and energy devoted to these symptoms or health concerns, so you need one of those. And as with anxiety disorders, we're looking for this to have affected your life for about 6 months or more. And if you meet these criteria, then we specify whether pain is the predominant problem and whether symptoms are persistent. And the DSM reminds us here that the individual's suffering is authentic, whether or not it is medically explained. This is relatively new guidance, and it's kind of a signal. It says, we're not telling clients that they are delusional or wrong. We are attempting to describe, classify, and assist. Moreover, people may describe their problems differently and idiomatically. For example, if you tell me you feel burned out, I know what that means, but it's a rather idiomatic term. Someone else might have their own idioms for describing burnout, and let's say that idiom involves heat. Oh, I've just been feeling very hot lately. The fact that they don't have a fever doesn't really address their psychological concerns. So we mentioned that somatic symptom tends to be self-deception, and malingering is nearly exclusively other deception. One of the ways that we can distinguish somatic symptom clients from malingering clients is that somatic symptom clients tend to rate their day-to-day dysfunction rather conservatively and rather minimally. If I ask someone who's complaining of pain whether they have trouble reading the newspaper, a client with somatic symptom would likely consider it and think, well, it doesn't affect my ability to read very much, and so they would give a low dysfunction score. An individual malingering pain would say, well, yes, of course it affects my ability to read the newspaper. It's horrible, debilitating pain that I'm experiencing. This is, of course, not the only way that we determine whether people are lying to us about symptoms. We have specific validity scales, like those of the MMPI, that tend to be quite effective at catching malingerers. And when it comes to actual performance types of batteries, like when we ask people to memorize 3 things, or write their own name, or recite the months of the year, those with somatic symptom will do well. It's nearly impossible for most of us to genuinely screw up the months of the year, or to forget that the word albatross was just said to us 5 seconds ago. But for some reason, most people who are malingering will make these types of errors. To quantify what this type of failure implies, malingerers overshoot their target of poor performance so far that they tend to test as intellectually disabled. So one might read their test scores and think, well, if I took these seriously, I wouldn't believe that you could make it to my office on your own. There are also differences in patterns of verbalization between malingerers and people with things like somatic symptom disorder. Someone with somatic symptom might comment that they're doing poorly, but actually perform quite well. The pattern for malingerers tends to be that where they give a passing performance, they'll make excuses for that performance. Like, oh, I must be having a good day. This is normally much harder for me. Another verbal difference is that malingerers will typically give you the superordinate category types of problems that they have, like I'm tense, anxious, and have difficulty concentrating, whereas somatic symptom sufferers will describe specific moments and instantiations of that tension, or times and instances where they have difficulty concentrating. And given that you have these descriptions of how the clients think they did, and you also have the objective measures of how well they did, it tends to be the case that malingerers underperform compared to what we would expect from their symptoms that they've reported. And just like they told us when they were performing the task, those with somatic symptom tend to do better than they think they did, and then their list of symptoms would suggest they should. You may have heard of the term hypochondriac, which generally means someone who constantly thinks they're sick when they're not. There was a diagnostic category called hypochondriasis, and now most of the clients who would have qualified for a hypochondriasis diagnosis would tend to be classified as having somatic symptom disorder, though some of them may fall under illness anxiety disorder, which is a preoccupation with having or acquiring a serious illness, but this is in the absence of somatic symptoms. The presence of high anxiety, behaviors related to this anxiety, preoccupation with this for at least 6 months, and no other diagnosis that better takes account of this illness anxiety. And the specifier here is somewhat surprising, because there's a care-seeking type, those who frequently see doctors about their illness anxiety, and a care-avoidant type, where one has lots of illness anxiety, enough to meet threshold for diagnosis, but pursuant to criterion D, they tend to avoid medical care. And this care-avoidant type is actually the more common type of illness anxiety disorder. Notable here is the fact that concern typically is of a very serious disease. The disease being anticipated would warrant the anxiety. There's just nothing to warrant conjuring that disease. Next, conversion disorder or functional neurological symptom disorder. One or more symptoms of altered voluntary, motor, or sensory functioning, clinical findings that evidence incompatibility between the symptom and recognized neurological or medical conditions. The classic example you may remember from your intro psych textbook is the glove problem, which is just one example of the more general observation that people tend to have symptoms, tactile symptoms, that don't map to how the nerves are actually organized in your body. Criterion C, the symptom or deficit is not better explained by another medical or mental disorder. And criterion D is adaptive failure. You have significant distress or impairment. Some of the most dramatic examples of conversion disorder are of individuals with vision loss. There were a collection of cases from survivors of Pol Pot's Cambodia massacres, and these were individuals who were made to watch the slaying of their family members and other atrocities, and in part as a function of their survivor guilt, many of these individuals independently experienced, while safe in North America, the gradual or precipitous loss of their vision. There was no malfunction of the optic nerve, just the apparent conversion of unimaginable stress and trauma into blindness. The subtype of attacks or seizures is a particularly interesting one because individuals who actually experience full epileptiform seizures will present and behave differently compared to those who experience pseudoseizures, or what is more lengthily called psychogenic non-epileptiform seizures. For starters, a full epileptiform seizure may make you fall down hard, while those with pseudoseizures tend not to fall down, and if they do, they tend to cradle themselves and sit and lie down gradually. There were also some interesting experiments involving the syncing up of motion. So if someone's experiencing an epileptiform seizure, and I rhythmically move a part of their body, maybe I wave their hand back and forth or up and down gradually, when I let go, that person experiencing an epileptiform seizure will return to random motion because they're experiencing a seizure, random firing, and its consequences. Someone experiencing a pseudoseizure will tend to sync up to the rhythm that I'm making and continue the rhythm. This is just to say that there are ways to tell conversion disorder pseudoseizures from epileptic ones. For some historical context, conversion disorder used to be identified as hysteria, a medical category that doesn't exist anymore. Teasel and Shapiro did an experiment with individuals with movement subtypes of conversion disorder, and they presented them with an interesting double bind. What they did was they told these clients that, quote, full recovery constituted proof of an organic etiology, and failure to recover from their movement disorder was evidence of non-organic or psychiatric etiology. In other words, if you have a biological problem, you'll get better. If you have a psychological problem, you won't. The clients to which they gave this information improved dramatically and rapidly. I'll let you decide what that means. Continuing in the classification category of somatic symptom and other disorders, we have psychological factors affecting other medical conditions. This is where you have a medical condition, but something, maybe illness, anxiety, that is psychological, is getting in the way of treatment or exacerbating the condition that you have. This is actually the most common disorder diagnosed in this category. It was mentioned that when the health concerns seem to be targeted at deception of other people, we have the categories of malingering and factitious disorder. And while malingering is not a diagnosis, factitious disorder is. And it has two primary subtypes. The first is factitious disorder imposed on oneself. Criterion A, falsification of physical or psychological signs or symptoms, or induction of injury or disease associated with identified deception. So you either lie about being sick or you make yourself sick. B, the individual presents himself or herself to others as ill, impaired, or injured. In other words, you're not doing this at home by yourself. C, the deceptive behavior is evident even in the absence of obvious external rewards. That's the criterion that distinguishes factitious disorder from malingering. If I can convincingly say that you're doing what you're doing for something like insurance money, then the typical determination will be malingering. If that motive is not apparent, then the typical outcome is factitious disorder diagnosis. I probably don't have to point out to you how the determination of a diagnosis based on the presence of potential motivation could be a problem. I am not justifying how things are done, just relaying it to you. A clear-cut case of factitious disorder might be somebody who says that they are depressed over the loss of a spouse, but the individual had never been married. Admittedly, this is a case where we would have to be very careful because it may qualify as delusional disorder. But if the point is to be seen as having depression, then factitious disorder may be the more appropriate diagnosis. An example of injury induction taken from actual cases is individuals injecting their own feces into their skin. And what we would do if it seemed that there was an obvious motivation for lying that was not just social but material, is we would write in the V code for malingering, which is not a diagnosis, it's just an acknowledgement of something important. But I mentioned that there were two subtypes of factitious disorder. The second you may have heard of under the term Munchausen by proxy, and it's factitious disorder imposed on another. The typical case is a caregiver imposing an illness on a child, but we could also do this with our spouses. If I lie about my wife's health or make her sick to get the attention or pity of other individuals, that would qualify for factitious disorder imposed on another, which is about 10% of factitious cases diagnosed. Completing the category, we also have somatic symptom and related disorder other specified. For something fascinating to Google, Google pseudocyesis. Not only do you believe you are pregnant, your body acts as though you are, something that also occurs in animals. Now that we've gone over the categories, let's look at some possible explanations for somatic symptom and related disorders. First, if you have a case of the MUPS, medically unidentified physical symptoms, maybe we just don't understand how they got the symptoms or how to measure them. Maybe there are nocebo effects occurring, which are especially powerful for things like tiredness, pain, and stomach discomfort. Maybe the cognitivists have it correct and the issue is primarily one of catastrophizing. Maybe individuals are coming to identify in the sick role, and maybe this is because illness is being reinforced by social attention or the negative reward of relieving individuals of their duties. As Boone puts it, humans likely have a residual evolutionary mechanism to display fake physical invalidity, shared with animals, which is more likely to be activated under conditions of environmental stress and threat, especially in individuals with deficient coping mechanisms. This seems highly relevant to our current situation, which is why I put it here. But having read that with words like fake, it's pretty obvious that there could be some pretty powerful diplomatic landmines buried just beneath the surface of this somatic symptom landscape that could explain the reduced attention the field has garnered recently and why cases might go undiagnosed. This DSM category of somatic symptom and related disorders is the only diagnostic category to, in recent years, see a decrease in research pertaining to it. I'm going to close this lecture by reading you two cases that should be classifiable in this category, but currently don't meet criteria. The clinician whose cases these are, Hope Goldberg, wants to see a category made for them called somatization by proxy in children and adolescents. The first case is a 14-year-old female who was expelled from school immediately before her 8th grade graduation. Prior to her expulsion, her father had 3 conflictual interactions with school personnel. The first was with a teacher who had given her a low grade. The second occurred when her father refused to use the crosswalk when picking her up after school, and the supervising teacher held her back by the arm to prevent her from following him into the street. The third was when her father was called in to talk to the school psychologist with his daughter about the first 2 events on the day prior to her expulsion. In the third incident, he yelled at and argued with school personnel and threatened to sue them. Witnesses described his attitude as entitled, insulting, and demanding, and his behavior as belligerent and inappropriate. Her father filed a civil suit against the school district on her behalf, claiming her arm was injured when the teacher prevented her from crossing the street, that she had developed PTSD due to the expulsion, and suffered functional deficits due to physical injury, headaches, fatigue, and severe emotional distress. Litigation was protracted. Orthopedic records contained no evidence that she sustained any documentable physical injury during the incident at school, and her somatic complaints were deemed inexplicable. No physical therapy was ordered. She received individual psychotherapy for more than a year after the event because her symptoms worsened over time despite administration of appropriately designed evidence-based interventions. Her initial complaints were feeling victimized and anxious. Over time, her symptoms increased in range and severity to include nocturnal insomnia, diurnal hypersomnia, depression, constant headaches, shaking, and fear of attending school, as well as feelings of guilt about and responsibility for her father's unhappiness with her academic performance. Psychotherapy notes included statements that she had a, quote, persistent, distorted sense of responsibility for and excessive fear of not meeting extremely high parental expectations, end quote. The psychotherapist informed her father that she was assuming too much responsibility for his psychological adjustment and happiness. Her father was discouraged from constantly focusing on her symptoms and expressing distress in her presence. In response, her father insisted that he had, quote, no expectations of his daughter other than her happiness, and only wanted to make sure she is okay. Defense counsel for the school district retained Hope Goldberg to conduct an independent psychological evaluation. Despite motions to include standardized tests, the court limited the examination to a clinical interview. Because no standardized testing was permitted, the burden of documenting symptom veracity rested on the clinical interview, which was 5 hours in length. Her father brought her to the evaluation. Before, during breaks, and immediately after the exam, her father made statements to Dr. Goldberg in her presence that emphasized her symptoms, including, she gets very tired, she needs to rest, or she will get sick. She needs lots of breaks. The shock of being expelled still makes her anxious. And she has headaches all the time and severe PTSD symptoms. With affective signs of grave concern, her father repeatedly asked her, do you have a headache? Is it making your headache worse? And are you tired? Do you feel sick? Maybe you should sit down and rest for a while. When asked to describe how she felt about the expulsion, she insisted she must have been responsible for what happened, even though she could not identify what she might have personally done to warrant expulsion. She stated her father has a right to have high expectations and to be disappointed in her when she does not make him happy. Her perception of her father's expectations was inconsistent with what her psychotherapist documented as her father's stated expectations. She reported she, quote, can no longer trust anyone because being expelled for no reason means that anyone with power could do the same thing at any time, end quote. She expressed concern about how upset and worried her father is, how angry he still is about what happened. She wistfully reported she had always wanted to be a lawyer because her father always told her she would be good at holding others accountable. But since her father has, quote, serious concerns about her health, end quote, she is no longer certain that she can achieve that goal. She endorsed a wide range of vague psychological and somatic symptoms, typically rated as severe and frequent, with onset immediately after her expulsion, all of which she attributed to the expulsion. She reported chronic headaches that interfere with her ability to concentrate and function during the day and keep her from falling asleep at night, feeling fatigued every morning upon waking, and decreased motivation and energy. She expressed fearfulness about everything related to school and commented, I will never be the same. I will never get over it. She stated that she feels sick in the morning when she has to go to school, that her heart pounds every time she is called to the principal's office, and she feels nervous all the time because her father is very worried about her ability to perform well in school because he considers her symptoms, quote, so severe. She mirrored her father's anxious affective states. In her presence, her father was hypervigilant to possible somatic symptoms, suggested they were or might be present, and expressed concerns about her current and future functioning as a result of the incident. Dr. Goldberg's opinion was that her father's behavior was responsible for the development and maintenance of her somatic symptoms and anxiety. Whether his symptom encouragement was conscious or unconscious was unclear, but his apparent anger and vengefulness toward the school district, persistent hypervigilance to his daughter's possible somatic symptoms, and her affective and somatic response to his distress predicted she would remain symptomatic. At the time of the evaluation, she did not meet clinical criteria for any diagnosis. Her father's behavior presented a significant threat to her long-term physical and psychological functioning. His behaviors were deemed likely to continue at least until the case had concluded in court, and prompt resolution of litigation was suggested in the hope that it might interrupt the intensity and frequency of her father's hypervigilance to and attentional reinforcement of her somatic symptoms. So, Dr. Goldberg would want that case to have a diagnostic category, specifically somatization by proxy in children and adolescents. I'll present another case of hers for which she makes the same argument. The parents of two boys, ages 9 and 13, sued the children's school district for failure to provide sufficient academic services to support their children's, quote, multiple needs, end quote. The litigation settlement agreement bound both parties to abide by the findings and recommendations of Dr. Goldberg's independent psychoeducational evaluations of both children. Medical records indicated high frequency of utilization for medically unexplained symptoms. Psychiatric and psychological records indicated both children had been evaluated numerous times by different physicians and psychologists at their mother's request to diagnose a wide range of symptoms and complaints their mother stated she observed. Both children had been diagnosed with multiple disorders, including ADHD, autistic disorder or Asperger's disorder, learning disorder not otherwise specified, impulse control disorder not otherwise specified, migraines, disorder of written expression, mood disorders not otherwise specified, Tourette's disorder, overanxious disorder of childhood, and obsessive-compulsive disorder. Both had been treated with various medications and intermittent therapeutic intervention. All medical and psychiatric records provided some evidence, either directly or indirectly, that the boy's mother was chronically anxious about symptoms she perceived were impeding their academic functioning, despite evidence of acceptable academic performance. 3 prior psychoeducational evaluations of each child had been conducted by the school district, and all indicated that both boys were scoring largely within normal limits compared to the same age and grade peers, with some of the 9-year-old's test scores falling into the superior and very superior ranges. All prior examiners concluded that the boy's difficulties were primarily due to behavioral evidence of ADHD, complicated by an unusually high degree of parental distress and anxiety, and poor behavior management and lack of structure at home. According to individual educational programs and teachers' reports, the children's emotional and behavioral problems were indicative of anxiety, attention deficits, hyperactivity, and emotional behavioral dysregulation. Teachers' reports and academic achievement records indicated the boys performed better in the classroom when on medications to reduce hyperactivity and increase focus and concentration. In contrast, the boy's mother reported that they functioned better when off the medications. Clinical interviews with the parents revealed an unusually high level of agreement about the boy's symptoms and adaptive functioning, but with the mother's symptom ratings somewhat higher than her husband's. Both parents reported that both children experienced nausea and gastrointestinal pain, migraine headaches, gagging, eating problems, insomnia, extremely high anxiety, clumsiness, fatigue, difficulty separating, difficulty making transitions between activities, twitching muscles, and facial tics exacerbated by anxiety, hunger, and fatigue, frequent temper tantrums, fear of death, nail-biting, impulsivity, delayed emergence of hand dominance, attentional problems, hyperactivity, and school refusal. The boys were typically permitted to stay at home from school when they complained of gastrointestinal problems or headaches or refused to go to school. When asked directly about their symptoms and complaints, both boys endorsed debilitating headaches and nausea that typically resulted in missing school, anxiety, tics, gagging, fatigue, and problems with attention and concentration. Both boys reported they did not like school, and both recited a list of diagnoses that matched their mother's report. In their mother's presence, the boys were guarded, whiny, oppositional, non-compliant, and clingy. Their mother responded to those behaviors with prolonged attempts to soothe them and meet their demands. She was typically unsuccessful in alleviating their distress, and seemed unaware that she was inadvertently reinforcing their behaviors. On one occasion, she was so frustrated by her inability to soothe the 9-year-old that she began to hyperventilate and gag and ran out of the office and vomited, at which point the evaluation was discontinued and rescheduled. She then recites a couple pages of test results, and I'll just skip to the summary and conclusion. Both boys were diagnosed with ADHD, the 13-year-old with primarily inattentive type, and the 9-year-old with combined type, and both met criteria for and were diagnosed with disorders of written expression. Recommendations were provided for treatment in school, home, and clinical settings. During the parents' debriefing, the majority of the time was devoted to educating the parents about how their own anxiety, symptom beliefs, and parenting behaviors were compromising their children's functioning. They were remarkably receptive to feedback, non-defensive, and genuinely appeared surprised to hear the extent to which their behaviors and perceptions had impacted their children. Both parents accepted referrals for individual psychotherapy to address anxiety and for joint parent training to improve their behavior management skills and increase their range of strategies. There are a few reasons that I chose these studies as the examples for this category. First of all, they belong in this somatic symptom and related disorders category, but they don't have a home there. Secondly, I'm hoping they illustrate the psychological and social dimension of somaticizing disorders. The 3 children from these 2 stories do not have control groups, so we don't know exactly how they would be absent their parents' malfunctions. But we do know that now the children have these challenges, and that it would be naive to say that these challenges couldn't have been prevented. By what, I do not know, but changes in the psychological and sociological dimension could have vastly improved these children's lives, as I hope was well illustrated in the parents' positive response in the second case study. But the point of case studies is to help you come to your own understanding, so I'll leave it at that. Stay tuned.